Hi everyone, today we're doing the practical of examination of the seventh cranial nerve, which is the facial nerve. Now, facial nerve, it consists of both a motor and a sensory root. Now, its motor part, it supplies a lot of the facial muscles, right? What are muscles of the facial expression, then your auricular muscles, which are of your ear, and then the stapedius. Other than that, it also supplies some of your glands, and very important, it has a sensory root as well that supplies taste sensation to the anterior two-thirds of the tongue. So you must have heard that the taste sensation, for example, if this is your tongue, so the anterior two-third, oops, so the anterior two-third, it gets its supply from the facial nerve, the chorda tympani branch of the facial nerve, which is your cranial nerve 7, right? Now, when you talk about the posterior one-third, so posterior one-third gets its supply from the glossopharyngeal nerve, which is the eighth cranial nerve, right? Yes, moving on. Now, when you talk about the entire tongue, if you talk about the motor supply of the tongue, so these were the sensory supply, right? When you talk about the motor supply, so that's given by hypoglossal. So basically, the muscles of the tongue, they're innervated by the hypoglossal nerve, right? Hypoglossal is your 12th cranial nerve. Now, what about the facial nerve? How many nuclei does it have? It's very important for you to learn these four nuclei. So first of all, the motor nucleus. So, motor nucleus, what does it supply? It supplies the muscles of the facial expression. Then I told you it supplies the muscles of your ears, auricular muscles, and then the stapedius muscle. Important, right? Then the second is sensory nucleus. Now, sensory nucleus does what? It supplies the taste sensations to the anterior two-thirds of the tongue, right? Other than that, the floor of the mouth as well as the palate. These all are given sensory innervation by your sensory nucleus of the facial nerve. Then you have a superior salivatory nucleus. Superior salivatory nucleus. Very important, learn its name. Now, this nucleus basically supplies the submandibular as well as the sublingual salivary glands and the nasal and palatine glands. Then you have the lacrimal nucleus. Lacrimal nucleus, as the name suggests, it supplies the lacrimal glands, right? So if anyone talks to you about the nuclei of your facial nerve. So motor nucleus, sensory nucleus. Motor nucleus supplies the muscles of the face, so facial expression muscles. Then it supplies the auricular muscles. Then it supplies the stapedius muscle. Sensory nucleus, it supplies the taste sensation to the anterior two-thirds of the tongue, then the floor of the mouth, and then the palate. Superior salivatory nucleus, it supplies the innervation to the glands of your which is situated around your face, around your head region, right? So what are all those glands? Sublingual salivary glands and submandibular salivary glands, right? So submandibular and sublingual glands. Other than that, nasal and palatine glands. Then you have lacrimal nucleus that supplies the lacrimal gland. Easy. So these are the four nuclei of the facial nerve. So here there was no practical up till now because this was the theory that you need to know before moving to the practical. Now, when you're examining before that, let me just tell you that there could be some possible degenerations of the nuclei. There could be some lesions that are going to cause facial weakness. So how can you localize facial weakness? Now, facial weakness would be of two types. So if there's any sort of lesion or any sort of injury to your facial nerve, so if the lesion is above the facial nucleus, so we discussed the four facial nuclei, right? So if it's above the facial nucleus, then the person is going to have the upper motor neuron type of lesion. If it's below the facial nucleus, the patient will have lower motor neuron type of facial weakness. Now, in upper motor neuron type of facial weakness, what happens is that only, for example, if this is the face, right? So only the lower half of the face is involved. So if this is, let's say, this is the face of a person, right? So only the lower half of the face would be involved in, sorry, it's detecting it as a scribble and it's erasing it. So only the lower half of the face is involved in upper motor neuron type of lesion. What about in lower motor neuron type of lesion? In lower motor neuron type of lesion, both the upper half and the lower half, so as well as the upper half as well as lower half of the face is involved because upper part has So basically, this is something you need to know. I may not be doing this correctly because the presentation can vary from person to person. Sometimes it could also be, for example, in upper motor neuron lesion, it could also be if they're saying lower half of the face, so this much, like half of even the lower half of the face. And in upper, so that's upper motor neuron lesion, and in lower motor neuron lesion, it could be this way, right? I hope you're understanding what I'm trying to say. Now, in lower motor neuron type of lesion, both upper and lower half of the face are equally involved because spinal common pathway is damaged. There will also be loss of taste in the anterior two-third of the tongue. Now, there are two very important syndromes that could possibly occur. So, one is the Ramsay-Hunt syndrome, and then you have Bell's palsy. Bell's palsy is very commonly known, right? And Ramsay-Hunt syndrome, it got a lot of attention, especially when Justin Bieber got this syndrome, Ramsay-Hunt syndrome. Now, what happens in Ramsay-Hunt syndrome is basically, you must have heard of herpes zoster infection. So it's basically a viral infection that is going to be reactivated exactly where? In the geniculate ganglion. So in the geniculate ganglion, if the herpes zoster virus comes and gets reactivated, so this could potentially result in Ramsay-Hunt syndrome, where there'll be lower motor neuron type of facial palsy. So lower motor neuron type of palsy is where both upper and lower half of the face are equally involved. And other than that, they'll be very important. So there'll be facial palsy, but there'll be very important painful vesicular eruptions. So for example, if this is a ear of a person, there'll be very painful rashes here. So there'll be vesicular eruptions in the external auditory meatus. So that's how you can distinguish Ramsay-Hunt syndrome from Bell's palsy. What about Bell's palsy? Now, Bell's palsy is an acute clinical condition. This also results in lower motor neuron type of lesion. And in this, what happened is basically this facial paralysis of the affected side. Now, usually what happens, as I told you, it could either be the entire halves or it could be just this half, right? So one side of the face. So in that affected side of the face, a person's over here you have the corrugator muscle, and a person frowns, there'll be wrinkles. So those wrinkles will completely disappear. A person's face would be quite expressionless. If the person is trying to smile, so the smile is going to be lopsided, it's going to deviate towards the healthy side. Then in the affected side, there'll be saliva coming down, the saliva will be dribbling. A person's eye will be widely opened, he won't be able to shut it down, right? So there'll be a lot of things happening in the facial nerve palsy or the Bell's palsy. What is Bell's palsy? It's basically facial nerve palsy. Now, why does it arise? It occurs because of inflammation of facial nerve and facial canal. Because of any reason, if there's inflammation of the facial nerve which is passing to the facial canal, there'll be Bell's palsy. And there'll be lower motor neuron type of lesion. It can also be associated with hyperacusis. This is very important because a friend of mine, her sister had Bell's palsy, and she's telling me that she suffers from hyperacusis. This means that even if there's a very, a very low sound, if anyone is talking, even if it's a whisper or if it's a very normal low sound, or even a normal sound, so the other person, the affected person with Bell's palsy, is going to perceive it as a very loud and irritating and annoying, disturbing sound, and they're going to be probably it's going to be very painful for them to even perceive that sound. So everything will be very much exaggerated in the sense, especially in the hearing sense, right? Then there would be hypoacusia. Hypoacusia is when there is loss of taste. So the person cannot taste for a little time as long as Bell's palsy is not corrected. Now, yes, so this is a lot of theory. There are a lot of diseases that were discussed. We're going to again recap Ramsay-Hunt syndrome and Bell's palsy, but we're not going to do it right now because let's move towards the clinical practical aspect of it. This we're going to cover again towards the end. Now, examination of the motor part of the facial nerve. What's the examination protocol? First of all, obviously, you have to introduce yourself to the patient. You have to take their consent. You have to explain them the procedure. And first of all, you have to obviously explain them the procedure, and you have to assure them that they're not going to face any sort of pain. And then you're going to take their consent. Then you have to approach from the right side. That's also one thing, right? Now, normally, I told you, if you see the affected side, it's going to be expressionless. There'll be no expressions. There'll be dribbling of saliva. There'll be flattening of the nasolabial fold. Nasolabial fold, for example, this is the nose. These are the lips. So around the lips, you're going to see these nasolabial folds. It'll be flattened. The eye will be more widely opened on the healthy than that on the healthy side, right? Now, how do you test the motor parts? So for motor parts, first of all, you're going to ask the patient to frown. And if they frown and their wrinkles are visible, it means they're healthy and fine. If not, it means they possibly there's some damage to the facial nerve. The second thing is you have to ask them to you could ask them to shut their eyes tightly. If they shut their eyes tightly, as tight as their eyelashes are buried deep into their lower lid, right? That should be the case. If they're doing it properly, they're fine. If not, and you observe Bell's phenomena, what's Bell's phenomena? It's a normal phenomena in which the eyeballs roll backwards when you're closing them. So when you close them, for example, just try to close your eyelids. You can't see it, obviously, because your eyes are closed, but your eyeballs have completely rolled backwards. So only the white area is seen. So Bell's phenomenon is normal. But in the people who cannot shut their eyes, obviously because their eyelids are not closing, but their eyes are sort of, they're trying to just shut themselves. So there'll be Bell's phenomenon quite visible because eyelids are not going down, but the eyes are trying to close. So there'll be Bell's phenomenon. And because the eyeballs have rolled upwards. Now, next thing you have to ask them is to try and whistle. If they can whistle, well and good. If not, because whistling is practically impossible in facial palsy. Then you have to ask them to inflate their mouth, and if they inflate their mouth, you're going to, sort of poke your finger or tap with your finger on the inflated cheeks. So towards the weakened side, the airs will be easily blown out. So whistling and inflating, they go hand in hand. You can easily learn this. And then frown, facial expressions, and shut their eyes. And one thing is ask them to smile or show their teeth. If they can do both of these easily, well and good. If not, what will happen? That mouth will be drawn towards the healthy side. It means there's some issue with the Bell's. There's some issue with the facial nerve. Facial nerve inflammation can lead to Bell's palsy. So frowning and smiling, two things. Then ask them to shut their eyes, ask them to whistle and inflate their mouth. So how can you learn them? In order. Frown, and then you can say smile or show the teeth. Then ask them to whistle or inflate their mouth and shut their eyes. Right? Easy. So this is for the motor part. How about the sensory part? You might have already guessed. For sensory, as I've told you, that sensory supply of your facial nerve is mostly towards the interior taste sensation of the interior two-thirds of the tongue. For that, you have to take a spatula, and in that spatula, you're going to put the taste test swabs of four different types of taste. One is sweet. So for sweet, you're going to use sugar. Then the other is salty. For salty, you're going to use salt, obviously, common salt, right? Then you have your bitter taste. For bitter taste, we're going to use quinine, 0.5% quinine sulfate. Then you'll have sour. For sour, you can use citric acid, right? And if you talk about the tongue distribution, so usually the interior part, oh my God, the interior part, it tastes sweet. Then the back part, it tastes bitter. The sides are usually for sour and salt, right? I hope this distribution is clear for you. So you're going to ask the patient to protrude the tongue and then you're going to apply the swabs on spatula of different tastes. First of all, you're going to start with sweet or any of them, and then you're going to ask the patient to identify the taste. Once they identify, you ask them to rinse their mouth. So after every taste test, they're going to be rinsing their mouth, and it's best to taste the bitter one at the end because bitter is very long lasting compared to the remaining ones. Also, one more thing is that there's another taste which is umami. Now, umami is basically a very delicious taste, and it's usually of the meat extracts and glutamate. So that's umami taste, glutamate. And how about sweet taste? Sweet taste is usually sugars, aldehydes, and ketone group. Salt is usually the sodium ions. Then sour is usually acidity, and bitter is usually alkaloids. This is glutamate, right? So yeah, if there's loss of taste, that's ageusia. And in some cases, for example, in temporal lobe epilepsy, there'll be hallucinations of taste and also smell. So that's one thing. So anyways, we've completely done the examination of the seventh cranial nerve. So here, once again, let's just quickly revise the Ramsay-Hunt syndrome. It's also called herpes zoster oticus, a rare complication of varicella zoster virus. Uh, Reactivation characterized by triad of facial nerve palsy. So there'll be facial nerve palsy, there'll be ear pain, and there'll be vesicular rash in the auricle or the external auditory meatus, right? So these are the symptoms. There'll be ear pain, vesicular rash, and there'll be facial nerve palsy, right? And it's usually a rare complication of varicella zoster virus reactivation in the geniculate ganglion, to be precise, and this usually occurs in patients who have compromised immune system, or who are above 60, or who have had chickenpox, or who have had varicella zoster virus, but it didn't get treated properly, right? So this is the treatment. Obviously, antivirals, corticosteroids will be given, vaccination will be given, artificial tears will be given so that their eyes can close, because normally there will be Bell's palsy, right? And their eyes won't close. So this is basically Bell's palsy plus auricular pain and the ear rash. So yeah, so this is your Ramsay-Hunt syndrome. Let me just show you that image where you're going to find, yes, see, even um, Justin Bieber, he suffered from it, and you can see the images. Anyway, so moving back to this, yes. Then we have again Ramsay-Hunt syndrome. You can see here as well. Facial nerve, when it's exiting the facial canal, possibly at that time there'll be some sort of um, inflammation. This is Bell's palsy. Inability to close the eyes shut. There'll be asymmetrical facial muscle tone, sagging, asymmetrical smile, so all of that. And hyperacusis is basically where everyday sounds, they may seem unbearably loud, painful, and even frightening. So yeah, that's pretty much it.